Meeting is now being recorded.
Hello and welcome. This is Nancy Archibald from the Integrated Care Resource Center, or ICRC. ICRC is a technical assistance project of the Medicare-Medicaid Coordination Office at the Centers for Medicare and Medicaid Services, and it supports beneficiaries enrolled in both programs. ICRC is pleased to present this training curriculum on self-direction of home and community-based services for case managers in managed care organizations. This is Module 2, Implementing Self-Direction. In Module 1, we defined self-direction and learned how it is used to help deliver person-centered care. And now in Module 2, we'll cover the design and basic mechanics of the self-direction program. In the next module, Module 3, we'll look at considerations around implementing self-direction in a managed care context. And then in the last section, Module 4, we'll examine issues around program oversight and management. Each module is accompanied by tools and resources which can be found on the ICRC website at www.integratedcareresourcecenter.com. This training curriculum is presented by Suzanne Crisp. She's Senior Advisor at Public Partners, LLC. Welcome, Suzanne.
Thank you, Nancy. It's a pleasure to be here today. Let's look at the learning objectives for this four-part training course. First, our objective is to provide case managers, supervisors, and trainers with a foundation for a train-the-trainer model. Next, to increase understanding and appreciation for the benefits of self-directed practices, the role of individuals in choosing a self-directed model, supports available to people who elect the self-directed option, and how to effectively provide those supports. Our next learning objective is to incorporate principles of self-direction into current practices, and finally, to identify measures to streamline the enrollment process through consistency and resources and to ensure quality. Today's module will cover the following. We'll watch a person-centered video, and then we'll discuss takeaways from the video. We'll be supporting an individual's ability to make decisions. We'll provide an introduction to the essential mechanics of self-direction, and those would include employer authority, budget authority, individual budgets, information and assistance, and financial management services. Now we'll watch the video. This training video was developed by a New York School of Social Work and is meant to provide both good examples of practices and poor examples of practices of person-centeredness. As you watch the video, make note there will be some really good examples and some really poor examples of person-centered planning. You may even see yourself in the video in one part or another. So watch the video now, and then you'll see an accompanying facilitator guide that will help you with hints on discussing, showing the video and then discussing the video as in the trainer model. So have fun watching the movie, pull out the popcorn, and we'll talk about it in just a second. So let's talk about some key takeaways from the video. Remember to address the individual directly. I'm not sure that the case manager was talking to the member. It appeared that she was talking more to the granddaughter. And of course, this is exactly what person-centered planning is not. It's talking to the individual. It's giving the individual time to absorb what you are saying. I think that the member felt like she was confused most of the time and certainly was being led by both the granddaughter and the case manager. It seemed like the case manager was in a hurry. Of course, I know she's busy, as you are, but you have to remember that person-centered planning takes more time. It takes more deliberation. Ask open-ended questions and give the individual time to respond. I don't know that there was a lot of listening going on with the video. but I think after we talked about what should happen and what we saw in the video, you might have a better idea of how to slow down and really speak to the individual and let that individual speak back to you. The key here is listening. Finally, do not make assumptions about what the individual needs or wants. It's almost like the granddaughter and the case manager had preconceived ideas about what the member wanted. They had talked previously, and it sounded like all the decisions had been made. They just needed to talk the member into following their plan. So I hope that gave you a good idea of what not to do. There were a few instances of good things to do. The case manager was very polite. She did talk about self-direction, and it seemed like the member wanted to test the idea. So just keep in mind as you're having these discussions, and don't necessarily do what this case manager did. So now we're going to talk about the mechanics of self-direction. Self-direction is offered in two various authorities. One is employer authority and one is budget authority. Let's talk about employer authority first. This means that the individual can hire direct attendants and will train, manage, schedule, and dismiss them. The most common form of employer authority is to hire an attendant to assist with activities of daily living, for example, bathing, dressing, grooming, or instrumental activities of daily living, meal preparation, running errands, shopping. So basically, employer authority is hiring staff to help you with your personal care needs. Next, let's look at budget authority. This provides an individual with choice and control over what goods and services to purchase within his or her budgeted amount for services. It allows the individual to purchase goods and services that promote their independence or reduce reliance on human assistance. The purchases must relate back to an assessed need documented in the person-centered care plan. So, for example, building a swimming pool in your backyard would probably not be tied back to your assessed needs in the person-centered care plan. However, buying a microwave or a washer or dryer might be tied back to an assessed need for assistance with meal preparation, for example. About one-half of all programs offer employer authority. The other half offer only about one-half of programs offer employer and budget authority, and about one-half offer only employer authority. To be an authentic self-directed program, the program design needs to offer both employer and budget authority. Now let's look at individual budgets. Individual budgets represent the funds that are given to the individual, and that individual has control over those funds. In other words, it's the amount of Medicaid funds under the control of the individual to be used to hire an attendant, purchase items to reduce human reliance, or promote independence. It also can be referred to as a spending plan or a service cost maximum. The budget must be consistently and equitably determined across all individuals. Typically, it includes a monetization of the current cost of traditional services. The methodology must be available to the public. Let's look at calculating an individual budget. There are 4 different ways to calculate an individual budget. One is based on historical cost. In other words, the case manager retrieves and analyzes service dollars that were expended for the past year to project service expenditures for the current year. This may be expressed in an individual or an aggregate level or within tiers. This assumes that there are no changes in the person's needs from one year to the next. An individual functional assessment is another way to calculate an individual budget. With a functional assessment, medical, social, and behavioral needs are identified using a standardized assessment instrument. The cost of the assessed needs then are calculated in dollars or units. It is typically the cost of traditional services. What is very popular is a combination of both historical costs and a functional assessment, because this not only gives you an idea of what the person has spent in the past, but allows for changes for the future. Prospective budgeting is also a methodology that can be used to calculate an individual budget. This means that a specific budget amount is uniquely assigned to each individual, representing the amount of funds that may be authorized. For example, a family may receive $35,000 per year to provide services and supports to a child with a disability. This is more common in programs that are designed for intellectual or developmental disabilities rather than persons with disabilities and with elderly. Let's look now at providing you with an example of a budget, an actual budget. Let's say that Mary her needs have been assessed as requiring substantial assistance with bathing, dressing, grooming, laundry, and meal preparation. Asking Mary how she would like her needs to be met, she said she would like to have someone there every day, including the weekends. She would like a bath 3 times a week, lunch prepared every day, and laundry done each week. She would also like to purchase a microwave and purchase pest control services because her apartment has mice. Using the assessment results, the case manager, with Mary and her invited friends and family, determined that Mary needs 40 hours per week to meet her needs. Her needs being assessed at hiring staff and purchasing pest control and a microwave. Using the payment rate for traditional services as a base, the rate is calculated as follows. $20 per hour is the unit rate paid to an agency, times 40 hours a week, times 4.33, which is the weekly rate, equals the cost of a traditional service plan as $3,464 per month. We'll look at the next slide now. Most programs deduct the cost of financial management services and self-directed counseling or information and assistance. Plus, the program may wish to ensure self-direction costs less than traditional services. So Mary receives a discounted self-directed budget of $3,000 per month. Mary decides to use $2,500 per month to purchase the services of an attendant. She establishes the rate of pay that includes an hourly payment to the attendant, plus employer taxes and insurance, and the consideration of workers' compensation. Mary decides to spend $100 with the authorization from her case manager to hire a pest control organization to rid her of mice, and $400 for that month to purchase a microwave oven to help her prepare her own meals. After the microwave and pest control purchases, she decides to spend the entire $3,000 to hire an attendant for the next few months. She and her case manager will assess her budget needs if she decides to make other purchases. Let's look at now the required self-directed support system. Medicaid requires 2 functions to be available in all self-directed programs. The first is the provision of information and assistance, and the second is financial management services. Studies have found that these support services are essential to a successful self-directed program. Information and assistance supplies the beneficiary with information about self-direction and assistance with selecting and managing an attendant. For example, this function would provide assistance with recruiting, interviewing, hiring, managing, and dismissing attendants. It would also help to understand self-direction and would help with problem solving. The Financial Management Services entity provides assistance with distributing payroll, paying invoices, and deducting required state and federal taxes and insurance. In other words, all of the employment requirements. Let's look now at how information and assistance is different from case management. Case management, through the person-centered planning process, does several things. It assesses functional, social, and behavioral health needs. It develops service and recovery plans. It determines individual budget allocations. It monitors the provision of services. And it links individuals with community resources and safeguards health and welfare. On the other hand, information and assistance is a distinct support system to self-direction. It provides information, assistance, and support through the person-centered planning process. So tasks include providing an orientation of self-direction to the individual, explaining program permissibles, goods, and services, making informed hiring and managing decisions, identifying additional supports or resources. It assists with training staff. It develops a backup plan for emergency situations. And it assists the financial management services entity when problems arrive with timesheets or paychecks. And it offers practical skills training to the member. So as you can see, this is very different from what a traditional case manager provides. Let's look at now who performs the INA functions in managed care. There are basically three ways the information assistance functions can be performed. First and foremost is that case managers continue to support the individual after they are enrolled in self-direction. In other words, case managers' duties are absorbed, self-direction duties are absorbed by case managers. This is in addition to their already hectic and busy schedule. Next, a distinct service is created to perform this function. Sometimes this could be a new waiver service, and sometimes it could be selected through a request for proposal process to select a vendor to perform all the services. For example, the state might wish to issue an RFP and select from those bidding on information and assistance. For example, a case management agency could win the award and then provide information and assistance. This would also relieve the case manager from having those additional obligations. Sometimes the financial management service provider opens up a new unit and supplies information and assistance. And what they do is hire employment specialists to help an individual with all of the paperwork to complete when they are hiring a worker, and all of the paperwork for when they become employers. What we found is that this required support function is often lost within the system, particularly when it is simply absorbed into case managers' typical duties. We have case managers that have expressed that they just don't have the time to do these extra added things. So sometimes it doesn't get done, and then we have an individual who is self-directing that doesn't really know who to go to for questions or how to solicit help when they need it. So what we say is ideally the function is a distinct service within the design of the program, either a waiver service or an entity selected through a request for proposal process. Next, we're going to look at financial management services. So why do financial management services even exist? IRS has made it very clear that an attendant is always an employee. They are not an independent contractor. The individual can be the employer of record or a co-employer. If the individual is the employer, IRS has special tax procedures for publicly funded programs. Most payroll companies are unwilling and unable to operate in accordance with these special tax procedures. So therefore, FMS entities were created. If an agency serves as the co-employer, the attendant still has authority over who to hire and when the attendant arrives. Let's take a closer look at financial management services. These services perform administrative responsibilities so that the individual can focus on managing their own services and supports and not have the onerous task of reporting to IRS and withholding payments and paying taxes and insurance. The FMS ensures that taxes, employment, and insurance regulations are complied with and that compliance is maintained. Payments to individual providers are made in accordance with the budget. In other words, goods and services are invoiced and paid. And additional controls are in place to detect and prevent fraud and abuse. So how is the FMS selected in a managed care context? The health plan may select its own FMS provider through a competitive bid process and then contract directly with the entity. In some cases, the state has influence over the FMS and tells the health plan with whom to contract. In some instances, a state agency may handle these functions. It's best when health plans use the same FMS providers or provider. There's less confusion for the individual. Here's a tip for state or health plans. Make sure that the FMS understands its contractual obligations and that there are strategies in place to monitor the FMS performance. Now let's look at what is the role of the individual case manager with FMS. Basically, it is to exchange information about the individual, and it's actually a two-way street. The FMS needs to talk to the case manager needs to talk to the FMS entity, basically to report changes, either in the address, the phone number, if the individual is hospitalized, service budget changes, or any other information that is relevant to self-direction. We find that it's very critical for the individual to report when a worker terminates to the FMS. Sometimes we see workers take the extra timesheets that they might have had the participant already sign, and even though they're not working for that individual, they continue to submit timesheets. And unless the FMS is notified that the person is no longer working for that individual, then a fraud and abuse situation occurs. Also, if billing issues can't be resolved, sometimes the case manager might have to intervene. The most common problem is either a late or an incorrectly completed timesheet. Let's talk now about the takeaways from Module 2. We learned that person-centered practices focuses on the individual and his or her short-term and long-term goals. We know that employer authority allows individuals to hire attendants to meet their basic needs, and that every self-directed program allows employer authority. We know that budget authority allows individuals to make purchases to promote their independence, and we know that about half the authorities allow budget authority, so they have employer and budget authority. Information and assistance provides counseling to support the individual as they are self-directing throughout the life of the experience of directing their own care. The financial management services entities assist individual with employer-related responsibilities, such as timesheet processing, paying state and federal taxes and insurance, paying invoices for goods and services, and ensuring members do not go over their allotted budget. So now I'll turn it back to Nancy.
Thank you, Suzanne. A reminder that the complete training curriculum and all the accompanying resources are available on ICRC's website at www.integratedcareresourcecenter.com. You can visit ICRC's website for a variety of resources related to integrated care and sign up for our newsletter. If you have questions about the material in this webinar, you can submit them to icrc@chcs.org. Thank you for joining us.